Let's talk about schizophrenia. I apologize as this will be a longer one. The psychotic disorders are diagnosed based on duration of symptoms, which defines duration of treatment. I'll define the psychotic symptoms shortly. Brief psychotic disorder only requires one symptom and lasts 1 day to 1 month. If the symptoms persist for 1 to 6 months and there are 2 symptoms present, it becomes schizophreniform disorder. Finally, schizophrenia is diagnosed if there are 2 or more symptoms and duration is more than 6 months. Symptoms can be divided into positive and negative. Positive symptoms include delusions of grandiosity, paranoid delusions, or delusions that someone is persecuting you. Delusions of control mean that the patient believes someone is controlling their actions, and delusions of reference mean that they believe something public is specifically for them, such as a radio broadcast or a hidden message in the weather forecast. The next category of symptoms is hallucinations, which include perception of auditory or visual stimuli that don't actually happen, such as hearing voices or seeing objects or people. Finally, disorganized speech, including word salad, where gibberish or words that make no sense together are strung into a sentence, and tangential speech, where the speech never really gets to a point or destination. One of the 3 symptoms already mentioned must be present for a diagnosis of schizophrenia or schizophreniform disorder. Behavior that is grossly disorganized, or catatonia, is the final positive symptom. The negative symptoms include flat affect, which is essentially outwardly appearing to not have a mood, anhedonia, and the 3 poverties: poverty of speech, called alogia, poverty of motivation, called avolition, and poverty of movement. Patients may also have cognitive decline, but this is not a negative symptom and is not necessary for diagnosis. Schizophrenia is more common in males. Onset is usually after a stressor and most commonly occurs between ages 15 and 35. Genetics play a role, and marijuana use is correlated with schizophrenia. However, this relationship may not be causal. Marijuana use is associated with a higher severity of positive symptoms, however. Diagnosis is made by the clinical criteria described after ruling out intoxication by drug screen. Mood symptoms should be screened for, as schizophrenia with a mood disorder is called Schizoaffective Disorder and may require different treatment. Speaking of treatment, patients with schizophrenia may benefit from psychotherapy. Acutely, especially for agitation, haloperidol, possibly with lorazepam and diphenhydramine. Acutely, especially for agitation, haloperidol, possibly with lorazepam and diphenhydramine as adjuncts, may be used. First-line maintenance therapy is with second-generation antipsychotics, which I discuss in my antipsychotics video, which I'll link in the description. Quetiapine, olanzapine, and risperidone are good options. Haloperidol, risperidone, and paliperidone are available in long-acting injections, which can be used to help increase compliance. If at least 2 antipsychotics fail after trials of at least 6 weeks, clozapine may be used. It is generally very effective, but causes agranulocytosis just often enough that it is only approved in drug-resistant cases. Finally, these patients need a good social support system. Thus, the best form of psychotherapy is actually family therapy. So care needs to be taken to keep in touch with the family as well as the patient. Catatonia, which can include posturing and waxy flexibility. This means that they can hold a certain posture perfectly still, but you can try to move them into another position. After overcoming a bit of resistance, they can be moved into an unusual, difficult pose, and they will just hold it. In other words, much like a wax figure, they can be molded into any position and will stay there. They may also resist commands, for instance, instructing the patient not to shake your hand when you put it out, but instead they will shake it and not let go. This can actually be dangerous because of the muscle contraction, breakdown, and resulting rhabdomyolysis and even malignant catatonia that can occur. This is characterized by hyperthermia, tachycardia, tachypnea, and diaphoresis. Benzodiazepines are first-line treatment. Electroconvulsive therapy may be used in resistant cases or for emergent treatment in life-threatening cases. Antidopaminergic medication should be discontinued until the catatonia resolves. Another related disorder is delusional disorder. This is delusions for more than 1 month without other symptoms. So a brief psychotic episode with only delusions would actually become delusional disorder after 1 month, not schizophreniform disorder. The delusions are things like thinking you're Santa Claus or that you are married to a celebrity you've never met. Treatment is with second-generation antipsychotics and psychotherapy. There's actually a diagnosis called delusional symptoms in partner of individual with delusional disorder. Formerly, this was called folie à deux, which takes about a third of the time to say. Basically, a person's partner will start to believe that they are actually married to Santa Claus. Treatment is the same for both partners. Finally, we'll discuss major depression with psychotic features. It's exactly what it sounds like. Major depressive disorder for 2 weeks with psychotic symptoms during the depressive episode. I'll link the video to the mood disorder video below as well. Treatment is what you might expect, too. A second-generation antipsychotic with an antidepressant as well as psychotherapy. Electroconvulsive therapy is used in extreme cases. This can be contrasted with schizoaffective disorder. Schizoaffective disorder is schizophrenia with either major depressive disorder or bipolar disorder. There will be symptoms outside of manic or depressive episodes. Treatment is with second-generation antipsychotics for schizophrenic symptoms, an additional mood stabilizer for bipolar symptoms, or an SSRI for major depressive disorder. Major depressive disorder in these patients should be screened for mania and hypomania, as in any patient with major depressive disorder, to avoid triggering a manic episode with an SSRI. Psychotherapy, especially family therapy, may be helpful. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it.